Manchester, UK. He will present a talk about early cervical carcinoma, the case for less radicality. Welcome.
Thank you very much. I'd like to thank the organisers again and Professor Secretary for inviting me here. I'm going to talk about recent developments in treatment for cervical cancer, in particular early cervical cancer, and the case for less radicality. I know that goes against the grain, being a surgical oncologist, but sometimes we have to think about maybe that we should draw back a little and get the same type of outcome that we hope, which is a complete cure. The background, well, we all know cervical cancer it worldwide affects many women, over 500,000 cases per year, with 275,000 deaths approximately. Obviously, these are approximate cases because many go undiagnosed, particularly in Africa. Often, however, if they're diagnosed as an early stage, and this is usually in countries with a screening program, they can be curable, imminently curable, and in fact, we can often stop them from progressing into fully invasive tumours. The standard treatment for early stage cervical cancer in young women is radical hysterectomy combined with pelvic lymph node dissection. If a woman wishes to retain her fertility, the usual treatment is a radical trachelectomy with pelvic lymph node dissection, and that has now been proven to have similar prognostic outcome as performing a radical hysterectomy. So same cure rate if you choose your patients correctly and do a radical trachelectomy. However, the parametrectomy that's involved in both of these types of treatments can be challenging and is the cause of most of the complications of these procedures. They include significant blood loss, bladder dysfunction, bowel dysfunction, fistula formation, and sexual dysfunction. The late side effects of these treatments and quality of life are very important. The reason being that more than 50% of these patients that we're doing these type of operations on will be under 50 years of age. And as more than 90% of them with negative lymph node status will have long-term survival, well then any kind of complications will affect these women for many years to come. In oncology centres, ureteric injuries such as strictures or fistula formation should be under the 2% mark. Lymphocysts and lymphedema, it varies the quotes between 2 and 23%. Well, that will depend on the radicality of your lymph node dissection and the reporting in that centre. However, functional disorders of the lower urinary tract are much more common, and these, once again, are quoted between 5 and 76%. Now, that's a huge disparity in numbers, and once again, that's because of how the functional disorders are actually diagnosed, and also the radicality of the procedure that's been undertaken. Usually, these types of functional disorders are because of damage to the autonomic nerves supplying the bladder, bowel, and vagina. They can be injured at several points during the dissection. In the presacral lymphadenectomy, you can damage the superior hypogastric plexus. Resecting the dorsal paracervix, so the uterosacrals at the back, the rectovaginal ligaments, the hypogastric nerves can be damaged bilaterally. When developing the pararectal space, and also, once again, the dorsal paracervix, you can damage the proximal part of the inferior hypogastric and splanchnic nerves. And resection of the lateral part of the paracervix past the deep uterine vein, you can catch the inferior hypogastric plexus and splanchnic nerves. a resection of the cyclouterine ligaments can also damage part of the hypogastric plexus. What's the rationale behind drawing back slightly and performing a slightly more conservative approach to early stage cervical cancer? Well, it's the observation that the risk of parametrial involvement is less than 1% in women with favourable prognostic factors. And then leading on from that, is parametrectomy warranted if the risk of involvement is so low? Well, first of all, what do we mean by favourable prognostic factors? Back in 1995, Kinney et al. Looked at 387 patients treated for squamous cell carcinoma, which was confined to the cervix. They looked at the pathological specimens, and then they came up with what they thought were favourable prognostic factors. 21.4% of the 387 they felt had favourable prognostic factors, and they called them a depth of invasion greater than 3 millimetres, but no diameter no greater than 2 centimetres. So these are the stage 1A2s and 1B1s, early stage 1B1s. There was no LBSI, and in this group, no patients had parametrial nodal metastasis. Moving on from this, Al Covens in Toronto has looked at 842 patients, all having had a radical hysterectomy. They've looked at the pathology in that, and in the stage 1A1 and 1B1s, they found that there was positive parametrial involvement, particularly with older patients, LBSI, higher grade tumours, greater depth of invasion, or positive pelvic nodes. However, stepping back from that, the parametrial involvement was only present in 0.6% of patients with negative nodes, tumour size less than 2 centimetres, and stromal invasion of less than 10 or less millimetres. Well, the evidence so far has been based on small retrospective studies. So we're fairly early on in moving this forward. These small retrospective studies have looked at conservative management in early stage, low risk cervical cancer. And Professor Hatem, who spoke before me, his study with Naik et al., and now he's gone, I can say it's the first and still the best, looked at 17 patients with conservatively managed stage 1B1 cervical cancer. And what they meant by conservatively managed is that the 5 women who wanted fertility sparing surgery just had a cone biopsy with a stage 1B1 cervical cancer and laparoscopic nodes, bilateral pelvic nodes, no further up. 12 women underwent either a laparoscopic assisted vaginal hysterectomy or a total abdominal hysterectomy and pelvic nodes who didn't need their fertility sparing. So a total of 17 patients. And in those cases, they did not find any evidence of disease in the definitive treatment specimens, so in the loop or the simple hysterectomy. There were no cases of positive nodes in the lymphadenectomy specimens, and of a median follow-up of 29 months, it had no recurrences. So a small series, but an encouraging start. But maybe this is all just a chance. They've not had the unfortunate patients coming through yet. So there have been further retrospective studies, 8 studies in total. I won't go through each of them in detail because we'll be here forever. However, putting the figures together, 260 patients in total. There's a mix of histologies. So squamous cell carcinoma is the majority, adeno 59, and others 4. The stages, they're staged between 1A1 with LBSI and stage 1A2 and 1B1. 1B1 being the largest group. 80% of all of the cases were stage 1B1. At the time of all the reports going to press, 2 out of the total of 260 had relapsed. 1 had died. Of of those who underwent fertility-sparing surgery within that, there were 174 planned fertility-sparing, 163 became less radical, 56 became pregnant. There were 73 pregnancies out of those 56 women. Out of them, they've got 46 deliveries, and 8 patients were still pregnant at the time of these reports going to press. So 46 out of the 174 planned surgeries. Coming on to where we are now, because obviously this is all retrospective analysis. There are 3 ongoing prospective trials at the moment, evaluating a conservative approach in patients with low risk early stage cervical cancer. The first one, the CONSERVE trial, is a multi-centre trial. It's looking at early stage cervical cancer. It's looking at those with favourable pathology, squamous cell carcinoma of any grade, adenocarcinoma grade 1 or 2. They don't want LVSI in any of the specimens, and no high-risk pathology, so no clear cells, glassy cells, or unusual pathologies. They're keeping to the 2 centimetre cut-off, and this is obviously the kind of crucial cut-off. It's the one that we use for whether vaginal trachelectomy is a safe procedure to go forward with or not. Above this, we do seem to see more recurrences. And if they want fertility-sparing surgery, they're going for a cone biopsy and pelvic lymph node dissection. They're also looking at lymphatic mapping at the same time. Non-fertility sparing, they're going to get a simple hysterectomy and a pelvic lymph node dissection with lymphatic mapping at the same time. Their primary objective of this trial is to have a look at the safety and feasibility of performing conservative surgery. Their secondary objectives, they're looking at morbidity, quality of life, and the sensitivity of the lymphatic mapping, so they can extend that in the future for looking at sentinel nodes for endometrial cancer. The sample size they're looking for is 100, and they've recruited 25 so far. It's based around the MD Anderson Hospital in Texas in the US, but now it's become international. I think they're recruiting from Melbourne in Australia and places in South and Central America. The next trial, and to my mind the best of the 3, is the Gynecological Cancer Intergroup trial. It's a randomised trial. This is what we really need, comparing radical hysterectomy and pelvic lymph node dissection directly to simple hysterectomy and pelvic lymph node dissection. The inclusion criteria are stage 1A2 or 1B1. They're going for the 2 centimetre cut-off again. Squamous or adenoma can be included, all tumour grades and LVSI. And this really is reflects in the real world in what we see, because the vast majority of our cases, the majority of our cases will have LVSI in. And so if we excluded these patients to undergo conservative treatment, then we'd be excluding a large proportion of our early stage cervical cancer patients. They do want less than 10 millimetres per patient on their lead or LETs, whichever you want to call it, and they want less than 50% of cervical stromal invasion on the MRI scan. They exclude high-risk histology, the very early stage disease, which will do well whatever you do. Evidence of lymph node metastasis, obvious ones here. Evidence of extrauterine disease. If they've had neoadjuvant chemotherapy, they're pregnant or want to retain their fertility. They're primarily looking at survival, and that's the bottom line for us all as gynae-oncologists. However, they're also looking at treatment-related side effects, extrapelvic relapse-free survival, rate of sentinel node detection, rate of metastasis, surgical margins, quality of life. They're looking for 700 patients. And then there's the GOG trial, 278, with a snappy title of value. I won't even read that for you yourself. And it's looking. It's a multi-centre trial, and it's looking at quality of life issues really. It's including squamous cell carcinomas, 1A1 positive, LVSI positive, or 1A2 and 1B1. Once again, we've got 2 centimetre cut-off, any grade, and negative margins on of CIN on their leaf or LETs. They're excluding invasion greater than 10 millimetres and evidence of metastasis. What they're going to do is do a fertility-sparing surgery in those that want fertility-sparing, count biopsy of pelvic nodes, and non-fertility, they're going to do the simple hysterectomy of pelvic lymph nodes. Their minimal sample size is 200, but may go up to 600. So once again, non-randomised, and looking mainly at quality of life issues. My personal opinion on that is that it's the second one, the intergroup, gynecology group, randomised trial that we need to wait for before deciding on moving this forward or not.
Discussion will be later on.
Discussion will be at the adult session. Our next speaker will be Professor Mustafa Al-Haddad, clinical oncologist at Al-Asra Aini and Nasser Institute. He will give us a talk about radio